Are you a runner suffering with pain on the outside of your knee? Is the kind of pain that is so severe that you're quite worried about it and you're not sure what needs to happen to get it better? Lots of people suffer with this problem. And in today's video, we're going to talk about the most evidence, most well-researched ways to improve what we know as iliotibial band syndrome. My name is Ed. I run a physio practice in Southwest London, specializing in treating iliotibial band syndrome. So let's get started. Let's just walk through what tends to happen with iliotibial band syndrome, or ITBS. Often it can be a pain that comes out of nowhere. It can be very extreme. We can get a period of time where the pain is really, really bad and it stops people from bending the knee. It makes them have what I call the Tin Man effect, which is where they just don't want to bend their knee. And we can go into why that is in today's video. So the question is, what is ITBS? Now, in simple terms, ITBS is basically an irritation of one of the structures on the outside of your knee, and it's often due to running. Specifically, what we suspect is happening is there's a fat pad that lives on the side of the knee, and when you run, there's a certain amount of pressure that gets put over that fat pad. Now, ordinarily, you can go out for a run and not experience pain, and that part of the knee can tolerate you running. But sometimes if you do too much, or some of the risk factors that we'll go through later, can mean that it does more than it can tolerate, and more stress and pressure gets put through that area so that it reacts. And it can be very, very painful. And this is why the bit that gets sensitive gets pressure put under it when you bend your knee. So that's why lots of people struggle with bending their knee when they have an acute onset of iliotibial band syndrome, because the bit that's angry is getting compressed every time you bend the knee. Now, the iliotibial band is effectively an attachment site for all of the muscles that live on the side of the knee, and it also helps to keep the knee nice and stable as well in parts. The reason why ITBS exists is often most commonly due to an increase in training volumes. So someone may have been returning from injury and they've gone too quickly back into their training. Maybe they've increased their volume too much, they've increased their intensity, they've increased maybe some other training they're doing. So for example, they were running 3 times a week, but now they're running 3 times a week plus playing football, tennis, and something else on the weekend. And like I said before, there's this maximum tolerance to stress that the outside of the knee can tolerate. And once that is exceeded, often again due to a training error, this is the kind of reaction we get with ITBS, where we get really, really kind of severe pain on the side of the knee. Other risk factors, we may put biomechanics in there. So sometimes if you're running and the hip comes across the body and the hip adducts, that can be a reason why more load would go into that area. Hip abductor strength is something that we would want to test. There's plenty of people who have weak abductors but don't have iliotibial band syndrome, so it's not a predictor, but it's something that we would definitely want to be addressing. And sometimes cadence can be important as well. So steps per minute when you're running. If you have a really low cadence and that knee is allowed to go into lots of flexion when you're running, so there's a lot of knee bend, that again can be a reason why the ITBS would take too much stress. What are the tests that we use to gauge if someone has ITBS? Now, in the treatment room, we would have a good feel. Like ITBS, it's a relatively easy one to diagnose because you can find the girders tubercle and it's really, really sensitive. It's quite a shallow structure, so we can kind of put that as a reason that would increase the suspicion of someone with ITBS. We might do the Ober's test, which is also going to compress that area and give us a pain response that potentially might increase our suspicion of ITBS. We might be looking at dynamic stability. So we might do the single leg squat test. We might do the lateral step down test. And we're looking at what the trunk is doing, what the hip and pelvis is doing, what the knee is doing if we're getting any hip adduction happening, or the foot and ankle and what's happening there as well. That's going to give us a bit of an idea of why potentially the ITBS might be taking too much stress as well. We'll start to create a bit of a rehab plan that we can work towards improving and treating the root cause. Other tests that we would do in the treatment room would be, on the first session, would be measuring hip abductor strength. So we can use a handheld dynamometer, we can use an exhaustion test, so how many hip abductions someone can do in side lying before they reached failure, or we can do a side plank and see how long each side can do, preferably a single leg one to make it isolated to each side. So once we have, as best as possible, got a high suspicion of ITBS, that's when we can start to get to treating it, basically. And what I've described up until now is what we would call step one. So this is where we're identifying the root cause, identifying prognosis, how long it will take to improve, and what the steps and the plan we need to put together for our patient to get better. Step two is where we're treating the pain, reducing the irritation, so that we can move on to step three, which is treating the root cause. There's different ways that we could do that. Manual therapy may be something that we would use. It can be something like massage, trigger pointing, acupuncture, using Theraguns and massage guns. Can all be ways in which we might just reduce some of the muscle tone in your quadriceps and may give someone some short-term relief. But the best thing really is going to be unloading, deloading, reducing your training volume, taking away all of the aggravating factors, because your body is naturally going to be trying to heal and settle itself down in the fastest way possible, and going out running and constantly irritating it is just slowing that down. So it's not something we can fight against, basically. So that's going to be a huge part of how we get that patient in less pain. Ice can sometimes be helpful, equally so can heat, sometimes complex. This is where we use like muscle stimulators to switch on different muscle groups in the leg. There are all different ways that we could try and reduce the pain, along with taping. Again, that could be sometimes a useful tool as well. Once we're seeing a reduction in pain and the patient can tolerate more weight-bearing exercises and tolerate more challenging things like jumping, that's when we can move on to step three. And this is where we're treating the root cause. So often we find hip abductor strength as an issue, hamstring strength as an issue, and running style can be an issue. So ideally, we would be doing some work on the hip abductor strength. Side planks are helpful. We can use Captain Morgan's, we can use various different hip abductor strengthening exercises, hip hitching off a step, and sometimes lateral lunges as well. Really, it depends on how tolerant the patient is to load, in terms of which exercise we would choose. Running style would be something that we would want to do some work on. Often it's increasing cadence of steps per minute, and also thinking about the knee window. So if we can see that foot is landing across the midline when someone's running, that would be something we would try and address. Changing running style can take 3 to 6 months, but sometimes when we just make small changes, even increasing cadence, steps per minute, we can see changes happening with that knee window increasing as well. So small changes are what we're looking for there. Hamstring strength, largely we're going to be focusing on eccentric control. I really like prone hamstring curls, Nordic hamstring curls, single leg bridges, and we can target either the proximal hamstring or the distal hamstring, depending on how much knee flexion there is. If we're in more knee extension, we're going to target the proximal hamstring, and if we're in more knee flexion, we're going to target the distal hamstring. So that's important if someone's had that older hamstring injury, for example, a tendinopathy, because hamstring eccentric control is important for when we're running as well. And on top of that, we probably would be doing some general strengthening, some glute strengthening, some calf strengthening, and all of the muscles that are involved in running as well. Once we're happy that the patient's making lots of progress, we're seeing some strength changes, as soon as possible, we will start to look at some return to play tests. Now, they might involve jogging on the spot for a minute, jumping on the spot for a minute, some single leg hopping if we think it's appropriate. It may even be a 5-minute really slow jog on the treadmill. And these are all things that we're looking to not really get any reaction at all with, so that we can be sure that that patient's ready to go back to running. We'd also be wanting to make sure that the strength on each leg is improving at least, and ideally would be, to a similar level as well. And then we would, depending on the patient again, use a return to running program to incrementally over a period of time. So a more aggressive approach might be doing a 15-minute really, really slow run and stopping if that patient gets any pain, going all the way up to 30 minutes. If we get to the end of that 30 minutes and there's no pain at all, then we would set that as that baseline of where to build a return to running program from. But more often, someone's going to get a reaction of pain. And if we want to be more conservative, more cautious, then we might do a mixture of run walking, and that would be where we might do minute on, minute off, times 5 or 6 or 7, and incrementally increase it by 1 minute per day. And that kind of program might last for 6 weeks, 8 weeks. The patient might find it a little bit frustrating because it feels quite slow, but all the while we're getting all the benefits of running, but we're not irritating the injury and putting that patient back to square one. Once we're back to running, we've passed all the return to running tests, we're tolerating, small amounts of running, then we're in step 5, which is prevent and protect. And this is where we're going to be giving our patients a whole host of different things to be working on to stop the problem from coming back. Now, this would include some rehabilitation, some strengthening, conditioning work, probably plyometric training, and we're going to give them lots of education on training loads and how to avoid making a training error again. We may monitor their running style. That might be something that we would want to check in every 6 weeks. And we also might be doing strength testing to make sure that we're still making progress and we're still doing the work to stop the problem coming back. It's quite motivating when you can see your strength improving as a patient, and we've got devices to be able to do that in the treatment room. So it basically means that we can just keep monitoring and keep making progress. If you have any questions from today, you can leave any questions in the comments below. Also check out my most recent video on knee pain and how we treat that in my clinic as well. I hope you found today useful, and I'll see you on the next video.